obviously in San Miguel, and get their take and latest information and how all of this is affecting you. So with that, Jessica and Rebecca, I'm going to turn it over to you.
Good morning.
Good morning. I'm going to try and share my screen here.
Okay, I'm going to just take a second here to mute everybody and lock them out so that we can hear you. I'm having my own problems here.
Mute. Oh my God.
Okay, you're on.
Okay, my name is Jessica Frick, and I've been living in San Miguel de Allende since 2017. Prior to that, I worked in pediatric and adult intensive care and have degrees in biology, chemistry, and nursing.
And I'm Rebecca. I've been living in San Miguel since 2015. I work remotely as a public health social scientist and policy analyst for Canadian health organizations. So there's a world of misinformation out there, and it existed long before SARS-CoV-2 came along. So we started COVID-19 SMA because we felt it was more important than ever to provide quality information and resources at a time at which literally life and death could depend on it. Today, we want to share with you the most up-to-date information based on scientific research and public health authorities. But we want you to know that this information is changing daily. We're constantly moving. So what we want to talk about today is the epidemiology of COVID-19, community surveillance, the healthcare landscape in Mexico, some prevention measures, and before we close, we'll offer you our thoughts on what lies ahead. Finally, we'll give you a chance to ask some questions.
So here we go. So COVID-19, or coronavirus disease 2019, is the disease that is responsible for this global pandemic. COVID-19 is caused by a virus called SARS-CoV-2, or severe acute respiratory syndrome coronavirus 2. When we say novel, it's because it's a brand new virus that's never been seen before in humans. So viruses are everywhere and they're abundant. They're very small, they're not alive, and they can spread and they cannot spread without a host. Viruses are classified as either RNA or DNA, and that's really dependent upon how they get into a side of a cell and ultimately how they spread. Some common examples of diseases caused by DNA viruses are herpes and smallpox, and some common examples of RNA viruses are HIV and hepatitis C. Both RNA and DNA viruses can affect both humans and animals and can range from posing very mild risks to our health, like the common cold, or can threaten our lives, like with diseases like Ebola. However, the ways that DNA and RNA enter the cell and infect the cell are very different. And this is an important point because it really affects how easily or how difficult it is to make a vaccine. So here's kind of the simplified version. DNA viruses essentially knock on a cell's door. They move in, they make themselves at home, and begin having many baby viruses inside the house. Sooner or later, the house gets too full, and thousands of these newly made DNA virus neighbors are released into the neighborhood. They begin socializing, and eventually they do the same thing. When they're roaming in the neighborhood, it's really easy to tell a DNA virus from the other neighbors because they look differently. So making a vaccine for a DNA virus is fairly straightforward, if a vaccine can be straightforward, because the vaccine targets the invading DNA virus neighbors only and leaves the whole neighborhood intact. And there's a lot of vaccines for common DNA viruses. HPV. We vaccinate our pets against adenovirus, parvovirus. Healthcare workers get vaccines for hepatitis A and hepatitis B. So it's fairly common and straightforward, and scientists have gotten pretty good at it. RNA viruses, on the other hand, act differently and make it a little more difficult. Not only do they knock on the door and move in, but they inject themselves into the people that live in that house. And so now the people that are in there are like little spies because the virus is actually part of who they are. So the RNA virus inside the house, inside those spies, make tons of RNA baby spies that can easily now move out into the neighborhood and become neighbors that look just like everyone else. So no one's any the wiser. So these type of viruses are more difficult to treat with vaccines because the entire neighborhood looks alike. But inside, the function of these little spies is very different. So to kill the virus, you could potentially kill the entire neighborhood. So this is why making a vaccine for an RNA virus is trickier. So think about HIV, which is an RNA virus. After over 30 years, we still don't have a safe vaccine. But rather, what scientists have been able to do is develop a cocktail of drugs to treat the disease rather than killing off the virus itself. Lastly, RNA viruses are less stable and more prone to mutation than DNA viruses. So RNA viruses generally change and evolve faster. Think about influenza and how every year we need a new vaccine to it. These mutations also allow for the possibility of it jumping from one species to another, like with what happened during the swine flu when the virus jumped from pigs to humans. So this is exactly what has happened with SARS-CoV-2 virus. Initially, there were these coronaviruses that were circulating around in bats, which was perfectly normal because bats are a natural reservoir for this type of virus. Under normal conditions, coronaviruses from bats can affect other species. So they don't get into other animals, they don't get into humans. But remember from the last slide how we said how unstable these RNA viruses are. So after thousands and millions and billions of mutations, sooner or later, one mutation hit pay dirt and allowed the virus to cross the Great Divide, and it ended up causing a disease in another animal. A few million trillion more mutations created the perfect storm that allowed the virus from that second animal to now infect humans. So now this bat coronavirus is in a human for the very first time. So this means we have absolutely no immunity to it, and it's an RNA virus, so it's very contagious and very difficult to create a vaccine for. This is how COVID-19 began, and because it's the first time scientists and health professionals have ever seen it, they are truly learning each day about how to deal with it. So on December 31st, China alerted the World Health Organization about a string of pneumonia-like cases from a virus that they had never seen before, and it turned out to be this novel coronavirus. On January 30th, the World Health Organization declared it a public health emergency, and by March 11th, they declared it a pandemic because it had spread to every continent in the world except Antarctica. The first case was seen in Mexico on February 28th, and just 2 weeks later, on March 15th, San Miguel began proactively working to mitigate the spread, and this was weeks before the rest of Mexico followed suit. As of today, we are now in phase 3 of a public health emergency in Mexico and around the world. So as of Sunday, roughly 5.5 months into the outbreak, there are over 4 million cases worldwide with 279,000 deaths. This results in a fatality rate of about 6.9%. But this number is not necessarily accurate and is a bit of a moving target. This is in part because there are large numbers of undiagnosed or asymptomatic cases. So if the number of undiagnosed or asymptomatic cases is very high, the death rate itself would be much lower. Conversely, we're also starting to look at how deaths are classified. As we learn more about different presentations of the disease, we're also having to take a look back to how deaths were counted. For example, there may have been a death classified as a stroke that was really related to COVID-19. So if the number of death cases is higher, then the death rate would also be higher. So let's take a look at how the number of cases affecting an epidemic curve, which shows the number of new cases seen in a country each day. The horizontal line represents the capacity of the healthcare system within that country. Healthcare capacity accounts for things like the number of beds and ventilators, as well as things like the number of healthcare workers and resources like personal protective equipment that they have available. Usually, the healthcare system is working near full capacity. So when something like COVID-19 happens, even a relatively small increase in the number of patients can very quickly overwhelm the healthcare system. So two strategies to tackle this problem are flatten the curve and to raise the line. Flattening the curve is focused on diminishing the total number of people who get sick, and it slows down the rate at which new people get sick. While raising the line helps to actually increase healthcare capacity by making more hospitals available, more equipment, more beds. Now, in terms of mortality, the data shows that COVID-19 mortality rates differ by group. For example, if you split things out by age, you can see by this table that the fatality rate is relatively low if you're below 60. But then it really starts to climb up for the elderly. So they're the ones really at the highest risk for this disease. Similarly, the fatality rate is higher for folks with cardiovascular disease, diabetes, chronic respiratory disease, hypertension, and cancer. And of course, the elderly are more likely to have these conditions, so it's not surprising that they go hand in hand. Once a person is infected with SARS-CoV-2, they develop symptoms in about 5 days. This is what is called the incubation period, and sometimes these are called pre-symptomatic carriers. Now, there's a debate about how much asymptomatic people or pre-symptomatic people are spreading the disease, and it's more likely a lot more than was originally thought. Overall, based on current data, over 80% of the patients with COVID-19 have very mild infection, and some people don't develop any symptoms at all. For others, mild to moderate symptoms like fever and cough, shortness of breath are seen. Other symptoms can include fatigue, muscle and body aches, sore throat, and loss of taste and smell. Serious problems can include uncontrolled fevers, shortness of breath, chest discomfort, confusion, unresponsiveness, and blue face and lips. And unfortunately, critical cases can lead to pneumonia, shock, kidney failure, heart attacks, strokes, hypercoagulopathies, bleeding disorders, and/or liver failure. And finally, it's worth noting that there are many other disease presentations that scientists are only starting to recognize, highlighting that ignorance really, really is profound when it comes to COVID-19. In addition to causing disease, coronaviruses can spread quickly. It's increasingly clear that a lot of the spread is occurring through asymptomatic people or folks who are in that incubation period, many of whom are not at high risk at all themselves. It also spreads from those with symptoms like when people cough or sneeze and tiny droplets containing the virus are released. Recent studies suggest that SARS-CoV-2 airborne droplets may remain infectious for up to 3 hours in the air. In addition, SARS-CoV-2 virus can also survive on surfaces, and recently the New England Journal of Medicine published a study, and they found that it was still detectable on copper for up to 4 hours, on cardboard up to 24 hours, and on plastic and steel for up to 72 hours. These are the only surfaces that have been officially studied with the SARS-CoV-2 virus. There are other relations that they're making to other coronaviruses, but these are the only ones that have been specifically studied. So make sure you clean and sterilize frequently touched surfaces. To confirm the diagnosis of COVID-19, an RT-PCR test can be done. It's worth mentioning, however, that very early in the disease, the RT-PCR test can often miss the infection altogether. So that means it's not very sensitive. So if severe pulmonary disease is suspected, a chest CT is often done to detect viral pneumonia. And now there are even new rapid testing methods for COVID-19 that can get results within minutes. In Mexico, RT-PCR test is what is prevalent, and it involves inserting a 6-inch long swab into the cavity between the nose and the throat. The swab is then sent to a lab for analysis. This testing can be done by the government for free or through one of several testing facilities in this city. We have all the current testing information listed on our website, and we'll refer to that shortly. So we're going to talk a little bit about Mexico's testing strategy because it's kind of a hot topic. We're seeing two types of testing models in the world right now for tracking COVID-19. One is a passive model, which we are probably all the most familiar with, which is based on testing as many people as possible. The second is a model called the Sentinel Surveillance Model, and it was established jointly in 2006 by the CDC, the World Health Organization, and the Pan American Health Organization for monitoring influenza-like illnesses. These Sentinel models are used all over the world, and when they're properly implemented, they're very good at balancing limited resources while still allowing for prompt and flexible monitoring. In Mexico, we use the Sentinel model, and the system design is to test 10% of people with mild symptoms and 100% of people with severe symptoms. So if we take this point, the testing 10% of people with mild symptoms, if 100 people showed up with low-grade fevers, sore throat, they would test 10 of them, or 10%. And if the same 100 people showed up at the hospital with severe disease, high fevers, shortness of breath, chest pain, they would test all of them. And then through a sophisticated methodology, they calculate a factor in which to multiply the combination of these two cases. And in Mexico, the factor is 8 to 10. So what does this look like in the real world? As of May 10th, Mexico records 33,460 cases of COVID-19. Remember, this is based on testing 10% of people with mild cases and 100% of people with severe cases. Okay, so, oops, sorry guys. So if we take the 33,460 and multiply it by the 8 to 10 factor that is calculated specifically for Mexico, we get somewhere between 268,000 and 333,000 cases in San Miguel. And that's how the Sentinel model works. It also has plans built in that have certain thresholds. So when we hit a certain number of cases, or when a community transmission happens, different phases of the plan kick in, and this is what we've seen in Mexico. If you remember this slide, look at January 19th and January 30th. The Pan American Health Organization praised Mexico for being the first country to react and activate its emergency system. This is because of the Sentinel model. Mexico was one of the first countries in the world to develop a PCR test and enacted phase 1 even before WHO declared it a global public health emergency. Is it a perfect strategy? Absolutely not. And the novelness of the disease is proving itself every day. Neither the passive model or the sentinel model took into account the sheer number of asymptomatic cases or the length of time of that incubation period. Both of these things are unlike any disease the world has ever seen. And in countries using the passive model, which was that model that wanted to test as many people as possible, there's been issues as well, such as test development, lab processing, and some countries have even had faulty tests. So the takeaway is that this is new to the world and the world has just begun. And so we're using data to make, to look at patterns to see what the disease is doing. Skip asked us to talk briefly on whether Mexico has hit its peak. And the short answer is we don't really know. The peak is that needle in a haystack marker. Health experts say not to expect a single peak day because as with any other disease, the numbers in both new cases and deaths need to decline for at least a week to discern any real trend. Some health experts say you actually need 2 weeks because that would give a better view of how widely the disease is spreading. In Mexico, we have not even begun to see a daily downward trend, much less weeks. And at the city level, it's even more difficult because widespread efforts of social distancing were enacted so early and were designed to help us avoid that dramatic spike in the number of people that got sick. So instead, here in San Miguel, we've had a relatively flat rate, and the flatter the curve, the harder to identify a peak. Lowering the number of new cases is important, but it's really important to understand that it doesn't mean the virus is disappearing. It suggests instead that the social distancing measures that we've all been working so hard at have slowed the spread of the disease. We just don't want to focus too much on a peak because we're in a story of multiple epidemics and peaks, and all of the epidemics and peaks that we'll see in the future with this virus are really dependent upon the actions of the community, and Rebecca is going to talk about that shortly. So we want to share some information with you about the state and federal healthcare system and what it would mean to you should anyone need to be hospitalized with COVID-19. There are two health sectors in Mexico. There's the public sector and then there's the private sector. The public sector is also broken down into two groups. There's the group that are people that are employed by businesses or the federal government, and all of their budgets are maintained by the federal government. And then there's INSABE, so this is for anybody that has a CERP. Remember this because that's all of us with temporary or permanent visas here. It's also for the self-employed and the unemployed. And in the private sector, there's, think like private health insurance. So we have private insurance or self-pay. And under normal healthcare conditions, each sector has clinics and hospitals that serve each group. Hospital systems in Mexico are rated on a level-based system, with 1 being the most basic and 3 being the highest level of care, such as trauma centers or transplant centers. We have 4 level 3 hospitals in Mexico. 3 of them are in Mexico City, and I can't off the tip of my head remember where the 4th one is, but it's not in this area. So what happens if someone gets COVID-19? The majority of cases are mild and cared for at home. There is even a very large group of people who may go to the hospital for care but are never admitted and sent home to recover. This is an essential part of COVID-19, and again, the majority of people are cared for this way. Before COVID-19, most people had a pretty basic understanding of how the hospital systems worked in San Miguel. Hospital General is our public hospital. H+, MAC, and Unimed are private or self-pay hospitals. And we've either ourselves or we know someone that has had a procedure done at one of these local private hospitals. And we understand that the specialists come in from bigger cities to see these patients and often perform these procedures on specific days. Most people also understand that if you had chest pain, for example, and went to the ER at MAC, they would assess you and triage you. And if advanced care was needed, such as open heart surgery, that they would transfer you to a bigger facility within their system, maybe in Querétaro or Celaya. So they do this because those are the hospitals with the specialist and the advanced level of care that would be necessary to save your life. So along comes COVID-19. And the hallmark of this disease is that when it's serious, it is critically ill serious. And here, just like in the heart attack example above, experienced critical care physicians and nurses are essential to executing techniques that can save lives. So for public sector patients, Hospital General is the main COVID-19 hospital. They do have ventilators at Hospital General, and if somebody is critically ill sick, or say their number of beds are low because the facility is filled, they can transfer patients to a specialty COVID hospital in Leon or another specialized state hospital within Guanajuato. For private sector or self-pay patients, you may go to General Hospital, or where you can be assessed and treated the same way we talked about with public patients, or you can go to a private hospital. MAC, for example, has a tent set up out of their parking lot where they will assess, triage, and stabilize patients. But anyone needing critical care will be transferred to a hospital that can respond to the level of care that they need. This may be Hospital General, it may be the COVID hospital in Leon, or it may be a facility within their own system, such as in Querétaro or Celaya. There's also a couple of things related to private health insurance that we want to alert you to, but for time's sake, we would like to ask you to visit our website for full details about this information. The three main points we want to talk about is that the first one is that there has been some recent changes with an underwriter to most of the private insurance plans that support a lot of the travel policies and international expat policies, and there's a potential lack of coverage. So we encourage you to talk to your broker if you haven't done so already. This has happened about a week ago, to see if any of those things are in play for you. The second thing that a lot of people aren't aware of is that Ensambe is available for temporary and permanent residents. On that last slide, we talked a little bit about it, about the people that it was available for. If you are a temporary or permanent resident, you have a CURP number, which means you have Ensambe benefits. And again, we go over on our website in great detail about what you need to do to be able to print your CURP certificate to access those benefits. And then the last thing we just wanted to make everybody aware of is that the insurers and the hospital systems are asking for higher than normal deposits at hospital systems throughout Mexico. And this is for both COVID and any other type of care that is being seen. At that point, I'm going to turn it over to Rebecca and let her talk to us about prevention.
Okay, we've actually, I'm just a little bit concerned about time, so please somebody let me know if we need to wrap things up before I'm actually completely finished. I can do a quick summary. But basically, our hope is that you're not going to need the hospital system, but none of us are immune to SARS-CoV-2. So right now, we're all susceptible to getting COVID-19. So prevention is key. The virus is not going away. Our best bet is to avoid exposure and infection until such a time that a vaccine is available to us. Prevention measures are based on our understanding about the behavior of the virus, including its routes of transmission and how contagious it is. So quick recap on what we know so far about transmission. The main routes are through respiratory droplets. When an infected person coughs, sneezes, or breathes within a 2-meter distance of another person, and a droplet carrying that virus lands on them in their eyes, nose, or mouth. Another route is that the virus lands on the surface, and a person touches that surface and then touches their eyes, nose, or mouth. A third possible route is airborne, when smaller, lighter droplets carrying the virus are suspended in air. These can remain active for up to 3 hours. We don't know what concentration of virus you need to be exposed for COVID-19 to develop, so we don't really know how significant this particular route may be. Because of these routes, the goal of prevention is to reduce exposure of the virus. Given these routes, the emphasis of prevention has been on social or physical distancing, the most effective of which is stay at home. But prevention also involves hand hygiene and respiratory hygiene. So hand washing is one of the most effective things that you can do to prevent the spread of COVID-19. Soap and water work perfectly. And you've all heard you're supposed to wash your hands for 20 seconds, about the length of time it takes to sing Happy Birthday twice, or Queen's We Will Rock You. If you don't have soap and water, hand sanitizer with 60% alcohol, perfect. Carry it with you, use it often if you're out. Besides your regular hand hygiene, wash your hands whenever you've touched anything handled by other people from outside your home or any sick household members. You receive a delivery at your door, you take the box, wash your hands. You've been out shopping, touching the cart, touching the food packages, wash your hands. You use the handrail to climb up outdoor steps, wash your hands. And we can extend hand hygiene to all the different things that we touch. You're out shopping, you answer a call on your cell phone without washing your hands. It's possible you've now transferred the virus onto your phone that you're holding against your face. So items like your phone, keys, eyeglasses, things you touch frequently, you should also sanitize. And then of course, hand hygiene is also about not touching your face, especially your nose, eyes, and mouth, because these are the mucous membranes. That's how the virus gets in. When you're home, no one's sick in your household, you can be more relaxed about hand hygiene. But if anyone from outside your home enters, or if anyone in your home is sick, sanitize surfaces that are frequently touched on a regular basis. Think doorknobs, light switches, the fridge door, the remote control, those sorts of things. So respiratory hygiene is about reducing the spread of droplets that you emit when you cough or sneeze. If you don't have a tissue for sudden sneezes, sneeze into your elbow rather than into your hand. And always wash your hands after any cough or sneeze. To reduce your exposure to aerosolized droplets, avoid enclosed spaces that are not well ventilated. If someone inside your house is sick, or if you have someone from outside your household coming in, open a window. Another form of respiratory hygiene is mask use. If the person wearing the mask is infected, symptomatic or not, the mask may capture some of the larger droplets that could be carrying the virus. And this is the point of masks, to capture droplets from the mask wearer. It's not meant to prevent the person wearing the mask from exposure. So some quick key pointers: masks have to cover the nose, mouth, and go under the chin. Replace a mask if it becomes soiled or damp. Don't touch the outside of the mask. You can't pull it down around your neck or your chin and then pull it back up. Don't touch the outside. If you do, wash your hands. Wash your hands before putting the mask on, and wash your hands after taking it off. Wash your mask after every use with soap and water, and don't share your masks unless they've been properly washed. But it's really important to note, mask use does not reduce the need for social distancing or hand hygiene. Mask use is an adjunct to these measures, not a substitute. We've got a very long, sorry? Jessica? Jessica, did you say something?
I think Jessica froze.
Oh, Rebecca or Jessica? Okay.
Yes.
You can hear me though, Skip?
Yes,
Okay, so we have a very lengthy review of the science about mask use, including information about materials and safety considerations. So check out our website or Facebook group and you'll find that. Social distancing is a critical method of prevention. It's well established that limiting face-to-face contact with others reduces the spread of COVID-19. The recommendation is to maintain a 2-meter distance from other people, because this 2 meters is the typical range for respiratory drops to leave your mouth and fall. This means as much as possible, you should avoid crowded spaces, group gatherings, and any interactions that do not allow you to maintain that safe distance, including things like going to the hairdresser, getting a massage. And some people can spread the virus before they know if they're infected, so stay away from others even if you think that they're healthy and you're healthy. To show you, oh, I think with losing Jessica, we've lost the PowerPoint.
yeah, Rebecca, as a backup, I kept it here. I'm going to try to throw it back up. Yeah, because we did lose her. So let me see how quickly I can get.
Okay.
Oh, here she goes. She's back.
Okay.
She's back. She's getting it back on.
Into her spot. Jessica? So social distancing and caring for people who are sick requires careful planning and information. And our team has actually put together a few resources for you to use. We've created a couple of guides. One is the stay-at-home planning toolkit, which helps you limit your need to leave home. And the other is a home care guide, which provides you with information to help you take care of yourself or someone else who has COVID-19 at home. Jessica, can you just quickly go to the slide before? I just wanted to show you how important, how effective social distancing is. So it's estimated that an infected person, one person, can spread the virus to 2.5 people in 5 days, which is 406 people in a month, that if they're carrying on with their regular everyday lives. But if they cut their contacts in half, spreads reduced from 406 people to 15 people in a month. And if they restrict their contact by 75%, only 2.5 people may be infected. So this not only helps the individuals, preventing them from getting ill, but also greatly reduces pressure on the healthcare system. So social distancing is important. Check out our guides on our website, how you can do it, or how to make it easier for you. Okay, so looking into the future, we need to be realistic. COVID-19 is going to be with us until we get an effective vaccine widely distributed. We should brace for it to be with us for the next several years. There are 3 scenarios envisioned by scientists based on past pandemics and what is known about this virus. So the first scenario is that right now we're experiencing the first wave of COVID-19, which will be followed by a series of repetitive smaller waves throughout the summer and consistently over the next several years, gradually diminishing over time, with different hotspots popping up depending on the action or inaction of communities. The second scenario is that the current wave we're experiencing will be followed by a larger wave in the fall or winter, and then subsequent smaller waves. This scenario will require significant mitigation measures like lockdowns to drive down the spread of infection, prevent overwhelm of the system. And then the third scenario is that the current wave we're experiencing will be followed by a slow burn of ongoing transmission and infections. So like scenario 1, this pattern will be influenced by what prevention strategies are in place and how each one of us responds. But this scenario may not necessarily require strict mitigation measures, even though illness and deaths will continue to occur. No matter which scenario plays out, hand hygiene and social distancing and possibly mask wearing will be important. That'll be ongoing. And when we talk about mitigation measures, we're talking about those lockdowns, school closures, businesses shutting down. But during all of this, researchers are working away on treatments, developing antibody testing, and working towards a vaccine. So treatment. At this time, there's no cure and no effective proven treatment for COVID-19 beyond supportive care. The majority of people have mild cases, remember. They'll be able to care for themselves at home. But for those who develop serious illness, in addition to symptom management, there are a number of treatments that are being explored. Drug therapies, like those used to treat autoimmune diseases. You've all heard about hydroxychloroquine. Antivirals used to treat other viruses, antivirals like remdesivir. And then there's a convalescent plasma treatment, which uses antibodies from the blood of people who've recovered. Some of these are showing some promise, but the bottom line is that there's just not enough evidence to support any of these at this time. Testing and contact tracing are important tools for addressing outbreaks. Thus far, not many countries have been able to do widespread testing, but moving forward, many countries may take up the mantra of test, test, test. However, as Jessica mentioned, diagnostic testing is not perfect. There can be false negatives and false positives. But testing combined with contact tracing can stop the chain of disease transmission by identifying those who may be infected, treat and isolate them, and test their contacts. This allows for targeted isolation rather than widespread lockdown. This can be very effective because, as Jessica also described, this virus is sneaky. People can be contagious for a long time and often before they even know that they're infected. So contact tracing can get these people, including those who remain asymptomatic. But contact tracing is time and resource intensive. It requires large public health teams to track down and test people. For most countries, the spread of the virus has been too fast to be contained by manual contact tracing, given the resource requirements. But there's the potential of smartphone apps now. It could make it faster, more efficient, and at scale. Phone apps are being used to track the movement of others, collect data about other phones in the area, and send alerts to people about risks of exposure based on their location. Another approach to controlling the virus in the future may be through antibody testing, but we're still very far away from this. Antibody tests search for proteins produced by the body in response to an infection. These proteins hang out in the blood, sometimes permanently, after the person recovers. Lots of people want to get tested. They want to know if they've had COVID-19. They want to know if they now have immunity. They hope these answers are going to let them go back to their social life, back to their work. But currently, antibody tests are not able to provide these answers. There's so much that we still don't know. We don't know if those who have recovered have the kind of antibodies that will block future infections. We don't know how long these antibodies might stick around for, if it's for months, years, for life. We don't know how strong an immune response is necessary to provide immunity. So if someone was mildly sick or asymptomatic, they may not have any immunity at all. And another concern right now is whether the tests actually work. It's the Wild West right now, and a lot of companies are developing tests that aren't going through the rigorous process for proving accuracy. And test results are wrong way more often than you would think and is safe. Incorrect results could pose a danger if people are thinking that they're immune when they're not, and they're still at risk and at risk of spreading it. So there's a lot of limitations right now, and basically it's for research only. Ultimately, what we need is a vaccine. And there's hundreds of scientists working on developing a vaccine. And the good news is there's incredible collaborations happening between scientific teams across the world. Collaboration like we've never seen before in science. And drug safety, efficacy testing is all being redefined to try to accelerate the approval process and get this out there. So I'd like to end on this positive note, but we also need to be realistic about where we're at, and we're a long way from a vaccine. We still need human tests, safety trials to show that the vaccine provokes an immune response. We need a way of producing the vaccine on a huge scale. We need billions of doses to be produced, and this might require building whole new facilities. We also need a way of distributing the vaccine to billions of people across the world and actually vaccinating them. This also requires infrastructure that we might need to develop. Given all this, it's more likely to be 3 years before people are vaccinated at the numbers that we need to halt COVID-19. But here's our positive ending note. We have a great team of volunteer professionals working on our COVID-19 SMA project. This team includes translators, nurses, researchers, communications and IT people, and we're really lucky to have them and so grateful to each of their contributions. And together we're all really committed to providing the best possible information. So check out our Facebook group or our website. We've got a bunch of resources on there, and we're constantly updating with information, both general about COVID-19, as well as information specific to San Miguel. And now, how are we for time? Do we have time?
Thank you. Yeah, Rebecca, thank you. I made a message in the chat area and asked people if they had questions to type them in. Since we had close to 90 people in here, it'd be difficult to open up all the mics at once. So I've been trying to send them as we get them, but I know Nori, I want to unmute Nori for a second, and that might take me a second, because she wanted to make a comment about the combo, and I got to find her here so I can unmute her. Hang on for a minute. It's difficult with 90 people in the room. Let me do that. Here she goes. Okay. You're on, Nori.
Good morning, everybody. Thank you so much, Ron. And well, of course, thank you, Jessica and Rebecca. I think this information is extremely helpful and you guys are truly, truly amazing. I just have a concern because I'm part of a team of people that's also working with the community. And today on the civil list, probably one of the most irresponsible comments that I have ever read is out there. There are very well-intended individuals who, of course, want to help the community. Your social distancing comments and data are so on point, Rebecca and Jessica. And if we don't do everything we can in that regard, we're going to be in deep doo-doo, okay? There are some really well-intended individuals out there that are commenting about going out and helping folks and doing things. No one in their right mind should be doing that without going through a proper channel. So volunteers, they can, it's not a good idea for us as a community to just decide to go out there in different groups. This is extremely irresponsible. And I hate to go on the civil list, but today I'm gonna be forced to have to make a comment. So please, please, please connect with a group of professionals that's doing the work. And if you want to help through those professionals. I beg of you. That's my comment.
Thank you, Nori. I see David has his hand up here and is frantically waving. So let me see if I can unmute that. Go ahead, David. David,
can you hear me, Ron?
Yes, we can hear you.
Can you hear me?
Yes, we can.
Okay, first of all, I want to thank Gary and Ron for organizing this and for Gary allowing extra time. I would particularly like to thank Jessica and Rebecca and Joey, who's been working so hard. Joey's not here, but we know she's working in the background on testing. So thank you. Great presentation. My question is very straightforward, but also probably a little difficult. If you were advising the mayor of San Miguel in regard to reopening businesses in San Miguel, what would be your advice? In other words, obviously, as in the United States, there would be groupings. What would be the first group of businesses that you would advise him to open? The second, based upon your research? And I know it's your opinion, but I would really like to hear what you have to say. Thank you.
Thank you for that disclaimer, David. You knew it was coming. Rebecca, I'll start this and let you jump in. As Rebecca had talked about with the peaks and the waves and the myriad of what the future holds, the reality is we are going to have to look at how to reopen society. But to do that, we have to keep in mind how virulent, how contagious, how dangerous, how novel, and how unknown this virus is. If you were to ask me what we need to figure out first, it would be the medical community. We need to figure out how to safely go to a doctor's appointment. We need to figure out how to safely have preventative care. We need to safely know that if we are having chest pain, that we can go to a hospital and the hospital is prepared to handle that along with a COVID patient. So for me, in my own household, we've already been, talking about some of these things and what level of risk is important for us as a family to be able to enter back into society. So what would I say comes after that is a tough one for me, because San Miguel is such a special town, and there are so many components that make this such a community, and that includes our artists and our restaurateurs and our artisanal workers, and they all have life and they have family. So if you were to ask me what I think comes second, I don't know, Rebecca, is anything jumping out in your mind?
Yeah, absolutely. For me, the big concern is protecting workers. They are the ones who are in one spot for the entire duration of the day. If the space that they're working in, regardless if it's a store, a kitchen, an art gallery, if there's not good ventilation, if they're not given the equipment that they need to protect themselves. So really important to understand that mask use is primarily to protect the other people from, like it catches the drops, right? So if I wear a mask, I'm protecting you if I were to be infected, but I'm not protecting myself when I'm just going around my everyday life, and making sure that I maintain that safe distance and not staying in an unventilated, enclosed space for more than 15 minutes. So when I go into La Comer, great big open space, I'm in and out, that's okay. But the cashier who's in this space for a long period of time, that increases his exposure to the virus. So it is probably wise for workers to have access to masks, even if the general public is no longer required to do that as much, because they're in a high-risk environment, the same way that a healthcare worker may be. Now that might be an abundance of precaution even, but that's what our workers need. So good ventilated spaces, some social distancing measures that we are seeing being used by different businesses, including restaurants opening up. So I think it's really about thinking of those kinds of measures that are going to protect workers.
Ron, are there any more questions you've got on the chat? Ron?
I think Ron may have disappeared.
No, I'm here. We got one question from Melody. If you say that masks protect other people from the one wearing the mask, why do you want extreme clean and sanitizing masks every day? It's
a good question. Yeah.
So, I mean, the big thing with masks is there's a few ways that the virus can get onto the mask. One is by touching it. That's very common, that touching the outside of the mask. It's also possible that the virus lands on the mask if you're not doing social distancing, those sorts of things. So we don't want the mask itself to become a source of transmission for you. So I wear a mask when I go out. San Miguel municipal government has made that a requirement. And also, if I was an asymptomatic carrier or I'm pre-symptomatic and I'm still contagious, the mask could protect those around me from the droplets that I breathe, cough, sneeze out. But if I'm touching the mask and not wearing it properly, if I get a false sense of security, lots of research shows that people get a false sense of security. They think, oh, I've got the mask on, I can go right up to people, I can jump into that tomato pile at the store with reaching in with everybody else. But no, you need to maintain that safe distance, and you need to be washing your hands and keeping that mask clean so that your mask doesn't become a source of transmission for you. It's really important.
And I want to add to that to even simplify that even more is we talked earlier about the virus itself. The size of these particles are so minute. If you think of like a pinhead, there may be billions of virus particles living on the top of that pinhead. And these masks that we're making at home are made out of material that have fibers that are much larger. So if even a droplet lands on top of your masks and you breathe in, which is velocity, those particles are so tiny that they can come right through that mask. It does offer a layer of mechanical protection, but it is the size of that's why these N95s or these really, really high-tech masks work, is because they're meant to filter out these minute particles, whereas any of these cloths and things that we're wearing don't do that. And if you get enough layers together to do that, who's tried them? You can't breathe. And so like finding that balance is what's important. So that's why really like the simplified version of why wearing a mask and not touching it, not taking it off, not wearing a dirty mask, not sharing a mask, not doing any of these things is so important, because it literally can infect you.
Yeah.
Okay. Nori had one more question, which was, what is the current municipal order relative to wearing masks when out on the town?
It's enacted. It's still in place.
Okay. All right, I'm going to turn it back over to our president, Mr. Peterson.
All right. Thank you very much. This was a great presentation.
Wonderful.
I know Ron has recorded it. And Ron, where are you going to post it?
What I'm